work session.
Okay, let's get started. We also have a broken mic, I think. A work session today on prior authorization for rehabilitation services, and former Representative, now Senator Short, has joined us, as this was something that she had asked for when she was in the House, and we're going to be extra kind to her so that she'll remember this as she has gone over to the Senate. And as I continue to give her a hard time. So we'll start out with Heather Hammonds from Deer Park Physical Therapy, Chris Hempel, also from Deer Park, Stephanie Littrell, I think you're all coming up at once, right? Dr. Gina Wolf from Wolf Chiropractic, and Melissa Johnson. You can pull over the one there. And you may have to, you can pull, if you want to pull from around, how many, 1, 2, 3, 4, 5, all right.
Okay, so
We got it, okay. Okay, who's starting?
well, apparently I am. So, Madam Chair and members, it looks like back, I met with Shelley Short. I actually contacted her because we'd had dealings with Evicore, and they were actually going out and meeting with and contracting with other insurances. And we had some patients, which one we brought along here, that was severely impacted by some of these rulings or the authorization process, when we say it like that. Since then, some has changed, or maybe some more information has come to us, but very little. So I've actually sent over updated information showing that the process is long and arduous, and it doesn't allow for the benefit that the patients are, purchasing or needed most of all. It looks like that I was told that you guys could look up all those examples on your electronic billing books.
Oh, okay.
And we sent those all over yesterday. There was quite a bit, I guess. We sent several examples. This wouldn't be the first time, but
I'm going to interrupt. Can you back up a little bit and tell us just some of it, some of the background?
Absolutely. When a patient comes in, they are sent to our office, and it's on a recommendation or an order from a doctor. So they've been looked at by a doctor who says they need physical therapy for their medical condition. So when they come in and they have an insurance that has to go through a third party, the process, they don't just get the benefits that they've purchased that it says. So we can pull them up online. It may say they get 25 visits, but we have to send over a 3-page document or several different documents indicating that they're in need of physical therapy. I'll use Stephanie right now as an example. So when she came over last year, the benefit package that she had for physical therapy allowed for 25 visits per calendar year. We will send in, we do the one visit, we'll send over the authorization request, and we are told in writing, which is also in your electronic billing book, in writing from Evicore, Blue Cross, and all of them, that we should have this within 2 days. A lot of times, and I have several examples with date stamps on it, it can take up to 7 or more days. So when you're trying to see a patient that needs immediate care, and you get one visit in which takes 3 document paperwork where you're testing and you're doing all of that, and then they have to wait 7 days to start their care. And the first time around, we may get, it tends to be 6. I'm going to be honest with that. After that, in Stephanie's case, especially, which you'll see that, we'll get 1 to 2 visits at a time. Now, when they give us 1 visit at a time, it's not like we can treat on that visit. They come in, we use most of that visit for the required paperwork to get another authorization, that we may get 2 more. So that means we get, a very small amount of time to treat this patient. So she's unable to utilize her benefit package in a timely manner to be able to treat her. But not only that, we're doing so much paperwork that takes away from her visits. And that has severely impacted even her health. That's why she's here today, because if we could just treat the patient,
So when this happens and you filled out the paperwork, you send it in for prior authorization, is it always, I know sometimes always and never, but how long do you have to wait?
Well,
In this example that you gave,
well,
you
for
said you wait
Stephanie-
a week.
yes,
Is that normal?
no.
That-
No, if I've got a doctor, and like in Stephanie's case, we not only had a doctor who recommended it, we had a letter of recommendation in that, and we had an additional specialist that she went to that all three agreed she needed this care on a consistent basis. But yet, even since 2017, when her benefits rolled over, so she had all of her benefits left, they're still allowing 2 at a time. And again, it's 2 sounds like 2, but it's not really 2 that we can treat on. It's maybe 1.5 visits to 1 visit that we can treat on, because we have to do testing to resend all of this paperwork over to get authorization. And hers is broken down since her benefits rolled over in 2017. It looks like, how did that go?
Right here.
Yeah, in 2017, they rolled back over. And so she had her full benefit of 25 visits. When we sent in the authorization on January 5th, we received it back from Assurus. On the 12th, they authorized 2 visits. So one of those 2 visits is 3 sheets of testing and paperwork to ask for more. And then we might get 1 unit in. We might get 1 little treatment in on that visit. Then she gets a full treatment the next visit, and then we're waiting again. And it's the order that was sent over by the doctor was 2 times a week for 4 weeks. So all the doctors that involved are saying she needs this. There's a medical necessity. So we went as far as having 3, our office, her primary care, and an orthopedic specialist that looked at her. We all agreed, this is a medical necessity, this is no joke. And they're still giving us 2. Then we had to do it again. We sent another one in on the 17th. We received it back on on February 11th. So we sent it on January 17th. We received it back with a date stamp on February 11th. They again gave us 2 visits. So again, we're back at the first visit's going to be paperwork, and then the second visit we can treat, and then we're on a waiting game again. We sent another one in on February 11th. Wait, that was received. I'm sorry. How did that go? On the 25th, and we received 1 visit. So that 1 visit that they authorized, we ended up using to do the paperwork again, to wait again, to get more visits. And again, this patient was in need of her benefits that she has purchased. So she was in need of it. We were able to send in all of the letters of medical necessity so that we can say, okay, look, we've got this. We're not the only ones saying it. And we're still receiving 1 to 2 visits at a time, and it's breaking it up. And this is happening on a majority of our patients.
Go ahead, Jill.
Thank you, Madam Chair. Could you talk about one of the things that I thought was really important is that oftentimes what the insurance company is telling you and what the third-party benefit manager is saying is, are 2 different things. So they don't jive with each other, so you're getting mixed messages. Can you talk about that a little bit?
Where are we at on that?
Just generally.
The communications, let me pull those up, because again, I apologize. I'm just a tad bit nervous today.
You're okay. It's just really more general, where the insurance company would say you had the patient didn't need prior authorization, but then when you went through the third-party manager, then that third-party manager, you see what I'm saying?
We actually had this happen last week while I was out of town, where we're required to we try to call. It's very difficult to get through to, on our side, to like Blue Cross Blue Shield. So we go to One Health Port also. So I've had on several occasions, and again, this happened last week with the gal that was filling in with me. She called Evicore, who said, no, we can't even start one for you because this patient does not need an authorization under what we're looking at. So she went online to pull the benefits on because she couldn't get through to Blue Cross Blue Shield. It indicated on there that this was a plan that absolutely needed an authorization. So she didn't know what to do because it's not, they can't start something when they're not, Evicore's not showing that they need an auth. But when everything else is saying they do, I've, on more than one occasion, have called Evicore, and they've indicated that they didn't need an auth. I've actually gotten through to the plan, the plan would say they need, then we have to do this three-way call because the customer service and the one that I'm thinking of at the moment, it was Blue Cross Blue Shield, said no, they need an auth because the patient had also known that because she just signed the contract. She said, no, I truly do need it. And so then I'd have to sit on hold for 45 minutes. I have an example of Assurus just recently kind of doing the same thing where there was some sort of miscommunication in between the three, Evicore and the insurance company, and us trying to get the benefits. We at our office, I can't speak for everybody, but we do our dual diligence to make sure that our patient is taken care of, that they're using the right amount of benefits, that they've got the authorization in place. We try to make sure they can use what they need and less has to come out of our pocket. So there's a lot of time spent and finding out, does the patient need an auth? Does the patient have benefits? Does all of this? So we do go through those routines. I do know, and I know that you guys don't have an example of this, but as of Monday, PTWA sent out a survey. They sent out 92 offices. 727 patients have delayed treatment. So this is in 2 days, just 92 offices. That didn't include us. So it is not an isolated incident. We also have several letters from patients and other clinics that are coming in every day now that they found out that we're presenting this, having the same problems that we're having. So I do know this is not an isolated incident. It is not just our office. It's something common, and not just with PT, but also with massage. One of our letters is from a massage clinic. We have a chiropractor here. So it is not just our office having this issue. And my examples, it'll say that we, and give copies of emails, because I have tried to reach out and rectify some of this directly with them. The last conversation and conference we had with Blue Cross, there was an issue where Evicore stated 5 days. They said, no, that doesn't seem right. We've said 2 days. We put that in writing. So we're going to talk about this off of the phone, and we've never heard communication back. We tried to meet with Assurus, even a phone conversation. We have emails on that. To this day, it's never happened. So we didn't want to have to come here. We wanted this all to get streamlined where we all work together, but we just can't seem to get this all to work, mainly for the patients who are losing out. Stephanie really needs this care. Not only does she need it, she has also purchased a plan that should be providing something that is a medical necessity for her.
Stephanie, do you want to tell us about?
Well, basically I fell in my garage, and it's what started this all in November. So yes, in November I did get my 6 visits that you start with. That's great. And then we've got authorizations for more visits. But then when you start over at the beginning of the calendar year, it was a month that I had the 2 visits Heather's talking about, a month. That went 2 months. I had 2 visits in January till certain days in February. I had 2 visits in February till certain days in March. That doesn't get me back to where I need to be. I have a business. I'm a dairy farmer. I can't even milk my own cows right now. I've had to hire an employee to do what I do at our business. All I want is my 25 visits. Let me go. Let me get healthy. I should have been back able to do my job by now in my business, and I can't. And I just want to be authorized my visits. Please don't take a month before you authorize me more visits. And especially with these 2 visits a month, it spends most of the whole 1 visit on reevaluating me. Well, yeah, it's going to be worse because I haven't been seen. I mean, I have all the equipment. I'm doing all my stuff that I was instructed, my homework, as my therapist calls it, my homework, and I've been doing all that. But when you can only do so much at home because you're not the professional. That's not your job. That's why these people go to school, and they're very good at what they do. So I want consistency, and I want it to be so that there's not huge gaps in coverage for patients, because this isn't fair, and it's just not right.
And so did you have something that?
I think that we had a chiropractor that was going to speak.
Good time.
Yeah.
Madam Chair and members of the committee, thanks for allowing me to participate in this discussion. My name is Dr. Gina Wolf. I've been in private practice as a chiropractor in Spokane for the last 23 years. I own and operate a large multidisciplinary clinic. We have chiropractic, acupuncture, and massage benefits, as well as we have a MD that works right there within our clinic. And so I'm speaking specifically about chiropractic today, but I want you to know that I can mirror what I'm saying today into all three disciplines of non-drug care that are available to patients in our office. So I want to talk about this as a provider and an employer so that we can talk about the administrative burden. So we see what's happening with the patients, but when we talk about submitting an authorization, I want to get down into a little bit of the nuts and bolts of what that really means for us as healthcare providers. And I want to just preface by the standpoint of historically, patients, providers, and insurers have had a decades-old relationship. We're used to it. We understand the relationship to one another. And the infusion of a non-regulated third-party entity like Evicore into the doctor-patient relationship and into our relationship with the insurer has completely changed the face of how we do business, not just in how we interact with our patients, but how we run our businesses. And so let me start by the fact that requesting the paperwork, this was made available to you. It's a 3-page document, and this is what we have to fill out as providers. So 3 pages long for the visit allocation that she's speaking to. So we have to pull time away from our patient care. Now, while this is cumbersome, what we need to realize is that at the forefront of this is clinical judgment of the provider. So if healthcare was as easy as dropping it into a computer, that's all we would have to do. So healthcare is really driven around the clinical judgment of the provider. And when you look at this clinical worksheet, and we've actually done this in our office, we reverse engineered it and gave the patients the questions. They're that easy. This requires no diagnostic acumen. It doesn't require my clinical skill or experience, and it definitely isn't a good use of my time. So this is made available to you, and these are called the clinical request sheets. This is where the problem actually starts, because we may have a patient that fell in her garage, and she didn't just hurt her low back. She may have injured her neck and her shoulder. We're allowed to pick one body region to submit data into the online tool. So we have to decide which is worse, and then of that body region, we're allowed to give this limited clinical information that just doesn't give a clinical picture of a patient that's sitting here in front of us. And every patient that we'll see throughout the course of the day has a different clinical picture. So what we need to recognize is that the information that goes in when we request the authorization in the online tool is not patient-specific whatsoever. So there's 2 inherent flaws in this system. The information that we're allowed to give isn't patient-specific, and it doesn't completely depict the patient's clinical presentation. And more importantly, the information that we have to follow up with to show objective improvement. We're not allowed to have 2 authorizations concurrently. So in Spokane, we got dumped on all winter. We had snow right and left. We had people falling on the ice. We might have a patient that was actively treating with chronic neck pain that would fall on the ice and injure their low back, and suddenly we're only allowed one body region. We're not allowed to have concurrent episodes of care. And even our manipulative codes show that we treat more than one region at a time. So there's limitation in what the provider is able to put into the online tool. And then the online tool itself is the other problem. So she made it sound simple. We request more visits. I made this available to you in electronic copy. And what I'm holding in my hand is a screenshot of every single field screen that my staff has to navigate to get an authorization. So each one of these pieces of paper represents a separate screen that administrative staff has to go through to put clinical information in. Furthermore, once the provider's name is actually located on the screen, we're typing in our own phone number. We're typing in our own fax number. I can go on Amazon and they know what I bought on the 3rd Thursday of June in 2012, the minute I log on, but we have to tell the system who we are over and over again. So it's a tremendous waste of provider resources. And I'm here to tell you that the administrative burden of these authorizations frequently, with great regularity, exceeds the cost of what we're even reimbursed for the service in the first place. So especially as it relates to chiropractic care, it's well documented that we're working on reimbursement levels that are from 2003. That's when the minimum wage was $7.01. I had to hire a full-time staff person specifically to navigate the Evicore authorization processes in our office. So when I was going through this, quite frankly, I just said, what is medical necessity? You know, Premera has a version of it, Regents has a version of it. And as it stands, our state of Washington has a definition of medical necessity, and it's well documented. And I'm going to just, if you could just, I'm going to read here because it's so important that the medical determination process must include consideration of the treating provider's clinical judgment regarding the medical purpose of the requested service and the extent to which the service is likely to produce incremental health benefits. These are our patients we're talking about. Incremental health benefits is her getting back to work and getting back to the duties that she's done. And so when I look at this whole process, and I know we're limited on time, what I want to impress upon you is the administrative burden of this process is a horrible waste of the limited resources that we have as providers to start with. And it's completely changed our patient interaction because we're filling out the form instead of looking into their eyes and seeing what kind of day they're having. It's completely changed the doctor-patient relationship because instead of the provider and the patient and the insurer having a relationship that's well established, we now have a third-party entity sitting in the middle of the patient who needs care and the provider that wants nothing more than to get them better. But we have a non-contracted entity. We're contracted with the insurer, and the insurer is contracted with our patient. But the person who's providing this information, who, by the way, and I'm going to just say this blank, Evicore has a financial gain in denying these services. They don't have a responsibility to me in how much it costs my practice to navigate the countless hours of wasted energy and frustrated patients that we have to navigate. So I appreciate you taking the time to listen to me. One last little piece. I provided to you two pieces of correspondence that's kind of typical. I sent letters to both Premera and Evicore asking for a precise definition of data fields from this form. Now, that's a pretty objective thing to do. Can you please give me the definition of what a date of onset might look like? Pardon me? Oh, I'm sorry.
Another senator came in.
Looked like you were looking at it. So for example, I wanted to know what the date of onset was. I said, can you please provide me a definition? I got no reply from Evicore. I got no reply from Premera, and those letters were written in October. I have 14 providers in my office. I needed to know the answer, and I've yet to get an answer.
So the question I had for both of the clinics is, so are you only contracted with Premera and Regents that are using Evicore, or are you contracted with other carriers?
We're contracted mainly across the board. Evicore has really come into the picture lately, and why it's affecting a lot more of our patients is because so many people are, and this is my personal opinion, so many people are jumping on the bandwagon to get these third parties, and bottom line, why? Because they prove they save money. But how do they save money? By denying the benefits that a patient has chosen to purchase and can't use. And so this is at a great cost to the providers and the patients alike.
So do you have the same length of time problems with the other carriers?
No.
Okay. Representative Harris, you had a question? Yeah, go right ahead.
Thank you, Madam Chair. First question, so I was in an auto wreck. I had multiple problems. Are you telling me that you'd have to submit multiple applications for?
We can't.
You can't.
We can't. We have to deal with one body region at a time. We're only allowed to submit clinical data on one body region at a time. And I have to tell you, it doesn't matter what we put into the online tool because we get the same thing off the back end every time. It doesn't matter what we put in. All of your multiple injuries, we get the same amount of visits at the tail end of it anyway.
And just my QuickBooks Pro, just to let you know. So this does not auto-fill in for my $59.95 that I bought my QuickBooks Pro, that automatically fills in all my information. So you're telling me that every time you go in, it does not recognize your office again, and you completely have to fill in everything.
We have to go, we don't have to fill in every single data field for
But
our
we have to
practice,
go
but we
back
have to
and redo.
manually enter our
And
fax number.
Keep in mind, because I do have to say this, because one of the parts of the problems with the online that for me is the paperwork that I give my provider, because my provider's not going to be entering this, I am. And when I give it to them, there have been more than one occasion that I go to put it in and ask questions I'm not a physical therapist that I'm not going to answer. So then I have to go pull my physical therapist out of a treatment with another patient and say, hey, can you just look over, this is asking this, can you double check? So a lot of times if I know that the schedule does not allow for that, I will fax it over because they don't have a problem once I fax it over. So it really depends on the schedule. So, I mean, that would be the other thing. It doesn't always match when I go online what they filled out.
Well, actually, I have a question for Stephanie. And this, well, no, this is like, and maybe I should say you don't have to answer if you don't want to, but this has nothing really to do with exactly the topic, except, so did you end up taking more opioids because you couldn't get your therapies?
No.
No, okay.
She's not one that's going to
You
do
didn't
that.
take, you weren't on any pain meds?
No.
Okay, just checking, because that's one of the.
Tylenol, that's it.
Okay.
But I do have to say that is the norm, and
Yeah.
that is part of our responsibility here, is that when we limit patient access to conservative, empowering, educational, drug-free pain relief, when we start to close that access down, we're actually contributing to the opioid problem rather than being part of the solution.
Representative Short, or Senator.
Nice. I've done that to myself, by the way, Madam Chair. Yeah. So have you seen, just especially for those of you who are providers, have you seen that the care that the patient needs ends up extending a lot longer because they haven't had that appropriate upfront access to care? I mean, isn't it costing more in the long run, I would think?
I would think so too. The thing is we could get Stephanie to a point, I think, and I'm not a provider, but I've talked to our providers, where she could go back to work and she wouldn't, if we could actually give her consistency. So if you know anything about physical therapy, twice a month is not how it works. You have to be consistent with it. Most of the time it's 2 to 3 times a week for a month or two. And when we're prevented from doing that and you're only getting twice a month, then you're kind of starting all over. So when you're starting all over, then we've got to use part of that visit for the paperwork, and then we got to start all over. If you just give them the benefits to start with that they have, if we're showing medical necessity, and again, for Stephanie, we got to the point where we didn't want to be the only ones saying it because we felt she needed it. So she's now got 3 people behind her that are educated, that know what they're doing, that said she needed this, and they're still breaking it into small little increments where it's not really benefiting her. So that's a huge issue.
Do you have the same issue if it's like a stroke patient that's coming in for PT? Do they do, or does that get more of a bundle?
No, and I have to agree. No matter what you put in there, we're going to end up. You get
I
to
was
maybe
just
the
curious
6,
whether
and then it normally goes 2, then 1, then there's a huge pattern with it. No matter what we put in there.
So if I could take that a step further as far as costing more in answer to your question, Senator, the interesting thing about chiropractic benefits is they're self-limiting. We get 12 visits a year, and when you calculate out the patient's copay, when the benefit year begins, there's a finite cost associated with that benefit. So with the reimbursement levels that we have, coupled by the higher patient copays, many times we're going through this authorization process in order for the service to go to deductible. For the entire service, when a copay is actually is higher than our allowable amount, we still have to go through this process, even if the entire visit is patient liability. And if we don't do it, and I'm speaking to the what you were saying about verifying the benefits first, we go to 60% of this online tool. We go through 2/3 of this process on every patient, because if we don't and we find out that they needed the clinical certification, it's provider liability. We have to absorb the cost of that patient's care. We cannot bill the patient, we cannot bill the carrier. And so the financial risk to us is enormous as providers. So we don't just have the administrative burden to get payment from the carrier, we have to go through this administrative burden oftentimes for the patient to pay the entire amount themselves for those services.
And then to kind of take that, I have an example of this. This is big. This is a lot of money that was lost to one of our patients. She wanted us to look at that. Evicore allowed more. So we went on, we sent in the certification request and all that. They allowed more visits than her benefit allowed, which we were going, okay, we have in writing that this patient has been allowed this visit. They're seeing more of a medical necessity. How great, they're allowing it. We have it in writing. This patient right here is in debt for thousands because they've allowed more. She was under the same impression we were. They're allowing it. It's all in writing with the authorization number with an additional amount. She is stuck with, I think her bill at this point is $2,000, saying that she went over a benefit that was allowed by Evicore. But they're not going to reprocess it. They're not going to pay on her behalf, even though in writing it was allowed and authorized.
Okay, well, I want to give a chance to the two women that haven't said anything. Do you have something to add?
I'm good.
No?
Or, yep.
Madam Chair, members of the committee, I'm Melissa Johnston. I'm a physics teacher here in Olympia, and I have been on Primera for the last 2 years, and pre-authorization for my Primera policy started in October. I've been seeing my chiropractor on and off for 10 years, and my husband has been seeing my same chiropractor for 3 years. And when the pre-authorization through Evicore began, my 15 to 20-minute office visits ended up changing to 30 to 35-minute office visits because of the amount of diagnosis that had to go on to fill out forms. And when that diagnosis was finished, we had to wait to see if future visits would be granted. My visits have not yet been granted, and my chiropractor put in 3 weeks ago for those visits. And my husband's, it also took 3 weeks, but he was granted 6 visits to be used in a very short amount of time, in a total of 3 future weeks. So there's no way that he could actually do 6 visits in 3 weeks, and I understand that Evicore has an extension process, but that's more paperwork. My provider is leaving Primera basically because of the pre-authorization process, and as a member of the WEA has chosen to not contract with Primera, and according to my union representative, it's because the biggest complaint is the pre-authorization process that the members have to go through. The biggest piece for me, though, is as a patient, I have a real ethical dilemma with allowing a third-party, either computer algorithm or person, diagnose without meeting me personally. And from the research that I have done on Evicore, I don't even think it's a person that's making the decision on how many particular visits that you receive. And I'm wondering if there's even a person that looks at your case file and makes a proper medical diagnosis. So that's why I'm here today, and that was my testimony.
Okay. Thank you. Who had, Representative Caldier.
Thank you, Madam Chair. So this question's for both actually Stephanie and Melissa. So as a consumer, was it advertised to you that the insurance company would basically pay these in increments of 2 visits, or it require a prior authorization? And knowing this now, having the choice, would you go with another insurance company?
Absolutely.
Okay, thank you.
Okay. I think, any other questions here? All right, thank you for coming. And I know it was a schlep for many of you. So now we'll hear from David Baird, Vice President, Musculoskeletal Programs of Evicore, Dr. Todd Nakatsuka, Director of Chiropractic Services, Evicore, Dr. Mark Hyatt, Executive Medical Director, Regents, and Dr. Sean West, Medical Director of Primera.
Madam Chair and members of the committee, thank you for the opportunity to provide input regarding utilization review of outpatient rehabilitative services. For the record, my name is Sean West. I'm a practicing family physician and a medical director with Premera. Today I'll be speaking, and then my colleagues with Regents and then with Evicore will be presenting some information. First, I just wanted to say that listened very intently to the testimony that occurred before us, and I would just say that this is not the kind of experience that we want for our members or our providers. I think we'll provide some more information to add some context to these discussions. I'll say that in my nearly 2 decades of practice, I've had the opportunity to work with a number of outstanding physical therapists, occupational therapists, and other rehabilitative specialists. Early in practice, you start to learn where to send your patients based on how they respond, how many visits, and what the feedback is from those patients. You also learn that, just like many areas of medicine, there's quite a bit of variability in rehabilitative care. I can tell you that for the same cohort of a patient with the same condition, same age and gender, if I refer to one physical therapy practice, they'll get 6 visits. If I refer to another one down the street, they'll get 12 with no discernible difference in the outcome. So this is the kind of thing that I think all of us are trying to address as we're sort of grappling with appropriate evidence-based care and how do we account for that. Over time, providers, doctors learn where to refer their patients for the most effective and efficient care, but patients who self-refer often don't have that benefit of knowledge. So I think you're aware Premera has an obligation to do its best to assure that our members are getting the best, most evidence-based and outcome-based care and with good outcomes. This is something that our customers actually aren't just asking, that they're demanding that we do these things. So, there's quite a bit of pressure for us to look at these things and try to figure out how to assure that utilization is appropriate. So Premera participates in many local, state, and national stakeholder groups, including the Robert Reed Collaborative, promotes Choosing Wisely. I know the APTA has actually some recommendations coming out of Choosing Wisely, and we feel that these are really great opportunities to collaborate and want to continue to have those types of interactions. Premera is known for some time that rehabilitation services in our network are 2 to 3 times the national average. And our work with Evicore was not our first attempt to try to look at how we how we address some of that variation in utilization. Initially, we placed benefit limits on the total number of visits to perpetual visits with no clear endpoint, and this did have some results and some change in utilization, but it was a bit of a blunt instrument. Next, we asked massage therapists to have prescriptions for massage therapy, but that actually was quite burdensome for both the provider and the plan. We had a medical director go out and actually meet with 50 providers in the chiropractic community who seem to have unusual utilization, have conversations on medical appropriateness, and sent letters out to 272 other providers. And while we noticed that there was some temporary change in utilization, the patterns, they waned over time. So having tried and evaluated these alternative approaches with limited impact, we're now working with Evicore to assure services are being provided in an evidence-based and outcome-based manner. And I would say that member and provider experience are actually priorities at Premera, and it's very disappointing to hear some of the experiences. And I would say that I will acknowledge that the rollout of Evicore program by Premera was not great. We take responsibility for that. However, I'll also say that a lot of the issues that were problematic in the rollout have been addressed. And the issues that remain we're committed to working with Evicore to improve those. We have proactive outreach to several providers and associations to ask and solicit feedback on what the issues are and are actively working to resolve those. So I have confidence that the process will continue to improve. But the only way we're going to be successful in what we all want, right, for our patients or members or constituents is to get the appropriate care and have good outcomes. So I really think we're all trying to accomplish the same thing. In the end, what matters most to us is that the members are getting the care they need that is appropriate and evidence-based. So I look forward to continued collaboration with our provider network. So.
Thank you, Madam Chair. You know, a couple of things throughout your testimony kind of, I've kind of thought about, you talked about the variability of care. So if there's that much wide disparity of the care within that field, then how do you guys determine what's evidence-based?
Well, I could let Evicore speak a little bit more to that, but there's kind of practice guidelines, and it's sort of based on the type of problem and the standard care, but it is reviewed by peers in that same practice. So if it's physical therapy, it is actually reviewed by a physical therapist. If it's chiropractic, it's actually reviewed by chiropractic. So, you know, we need to there's sort of standard endpoints in certain treatments, and, you know, if there's no really sort of, I guess, oversight, then depending on the individual provider, that care can kind of go on for much longer than would be reasonably necessary. So it's an attempt to not sort of say, we know what's better than you, but here's some guidelines within which, you know, those services should be delivered.
Follow up, Madam Chair, thank you. So I'm kind of trying, can you take me through the folks that you employ to review these cases? Can you talk about their daily caseloads of the things that they look at an average day, making these decisions?
For that, I would have to defer to Evicore.
Yeah, I think that, yeah, you hire Evicore, so when we get to Evicore. So I'm guessing Regents was wanted to go next, or no? How do you want? Okay.
So I'm Mark Hyatt. I'm a physician. I work for Regents Blue Shield, and just addressing your question about variability. You know, there's a lot in medicine that's variable individual practices. As a radiologist, that's the type of doctor who's in the dark room and who looks at those MRIs and CTs, and for example, in terms of diagnosing back pain that my colleagues, chiropractors and physical therapists will subsequently treat. And I remember, a lot of days, about 50% of what I saw on my screen was in some way inappropriate or unnecessary. That is, my patients were being subjected to things that, because of this variability, just shouldn't have been done. And in some cases, they're actually harmful to patients. And so that's one of the things that really drove me into more of a mindset towards like the BRE Collaborative that my colleague here spoke of, where what we're really trying to do in medicine is to come to some foundation of evidence. There are guidelines, there is literature, there are things that we can rely upon, expert opinion. And so we're really trying to reach out to find out what's best for our members in terms of what are these nationally accepted guidelines, and not being subject to individual variation that may not be based in the science. And so I think that's something very important to point out. So I work as the Executive Medical Director for Regents Blue Shield, and in that capacity, one of my favorite things I do is I'm chairman of what we call our Medical Management Work Group. And this is an interdisciplinary group where we come together to look at the data pertaining to our members in Washington. And we have a lot of smart people there, smarter than I am, and they look at the data. And a few years back, we found in Washington this incredible variability. And we found that we were actually being deficient in the realm of musculoskeletal health for our members in the state. We found that we weren't managing things, that a lot of our members were getting care that was outside the norm, that was exuberant, that was in some ways inappropriate. And so we decided on that basis really to adhere to three fundamental principles that guide our philosophy. First, we're guided by the triple aim. I'm not sure if you're familiar with that. That was developed by the Institute for Healthcare Management, for healthcare improvement. And essentially, it focuses on three goals or three aims as part of this triple aim. One is to make healthcare more efficacious, to make sure that we're improving population health. Number two is to make sure that our members receive satisfactory care and quality care. And the third essential concurrent objective of this triple aim is to make sure that that health care is affordable. And you've really got to pursue all three. As you know, we're spending about 17% of our GDP. By 2020, it's predicted it'll be 20%. Unfortunately, a lot of that expenditure is on care that's inappropriate or unnecessary and in many cases harmful. So the first of three things that form our philosophy is the triple aim. The second thing, for me personally, that really informs me and inspires me is the BRE Collaborative, a marvelous effort within the state to really make sure that providers and clinicians align with appropriateness criteria. Bob Bree, its namesake, was actually my friend and my former mentor. And his vision is mine as we try to make sure that we adhere to the best practices. And the third, at least for Regents Blue Shield, is our cause. We have a cause, which is to be a catalyst to transform the healthcare system to make sure that it yields better outcomes and that it's economically sustainable. So those three things really form our decision, driven by the data, to implement a program in musculoskeletal health. I want to talk just briefly about how we chose Evicore. What we did is we evaluated intensely the different providers across the nation. Evicore was one of many medical benefits managers. And we subjected them to an exhaustive, thorough, year-long review. And we were impressed by Evicore's good numbers, which were to us a good measure, at least of their experience in this management realm. They weren't a newcomer to the scene. Rather, they have 1,000 clinicians, like Dr. Nakasuka, who will speak to us, I think, briefly, who himself is a doctor of chiropractic. They're the ones that make the medical necessity decisions. Regents, we really rely upon their clinical expertise. This is what they do. They themselves are clinicians. Secondly, Evicore is involved and partnered with over 500,000 providers in caring for 100 million Americans across this country. And they do so in handling about 4,000 cases just in musculoskeletal alone, not each year, but 4,000 cases, not each month, but 4,000 cases each day. So that means that just since I've been talking, we've probably handled maybe 50 such cases in this state. But it wasn't just their numbers that spoke to their experience, and why Regents chose them is also their quality. Now, Regents, we're subject to pretty intense pressure from an accreditation body, which is the gold standard in the industry, NCQA. Well, Evicore is also subject to that same accreditation oversight, NCQA, but not only that, also URAC. So there's pretty intensive review about these practices to make sure that they're best in class. So we evaluated and we chose Evicore as our vendor partner. Then we implemented the program. And I have to admit, okay, well, first let me tell you about the services that we do. We chose as a health plan that we needed oversight for physical, occupation, and speech therapy, for chiropractic, acupuncture, and massage therapy, and spinal surgery. And then later, we implemented also oversight for pain and joint management, because we really saw a need for that. I acknowledge that there were bumps in that initial grandiose implementation of a major musculoskeletal health program, but I want to really convey the sentiment that we were very strongly sensitive to our members, their complaints, their feedback, and we purposely shared this feedback with Evicore. We went a step further. We actually instituted a provider advisory council comprised of clinicians within the state. For example, we have a chiropractor, a physical therapist, a physiatrist in the state. We meet regularly with this provider advisory council, and they give us feedback which we share with Evicore to improve the process. I want to really convey the point that they're not a separate entity. This really is a Regents program. We contract with Evicore because they provide that clinical expertise to a level that is on par with the national best. And it's something that we can ourselves provide in terms of those 1,000 clinicians who and chiropractors and physical therapists that provide this expertise. Now, I want to say that even though we view them as our expert partner, we're really running the show. We're in close contact with our vendor partner. Let me just give you a few ways in which we do that. First of all, NCQA mandates that we oversee them very, very closely. We have daily communication. We have weekly operational and leadership meetings. Quarterly, we have these quarterly business reviews in which we subject them to our analysis about how well they're living up to their performance standards. We have interdisciplinary weekly complex case meetings, and that's where some of our members, unfortunately, with more complex cases, are discussed on a weekly basis in an interdisciplinary fashion. And we may find that maybe spinal surgery or something really invasive has been recommended, or maybe they're on opioids too incessantly, and we try to recommend alternatives, which could be chiropractic care, it could be acupuncture, It could be that someone does need the spinal surgery, but we do talk about our members and the best therapy that we should recommend to them, or at least encourage. Finally, we do have these process improvement initiatives. And so we do so with respect to our letters, our portal, our criteria, and our process. And what I'm trying to say is that things aren't necessarily perfect when you implement it. There are bumps in the road. I think that we're continuously trying to improve and evolve the program. And perhaps this manifestation, at least of that intent and effort, I have provided to you hard copies of a letter that we received just at the beginning of this month from the Office of the Insurance Commissioner, which states that they're pleased with the refinement of the program, with some of the improvements we've made to help providers more easily access the services and upload the information to Evicore that they need to, and that their original concerns have been addressed, and as a result, the number of complaints from both consumers and providers has declined. As a result, the Office of the Insurance Commissioner is closing its market conduct continuum with no further action required. This doesn't mean our efforts to improve will stop. They're continual, and they're daily, and they're evolving. And we really appreciate this opportunity, Madam Chair, to share with you at least our philosophy and the background for why we instituted this program.
We have a few questions for Senator Short.
Well, I don't know where to start here. Okay, so I think just kind of fundamentally when a person, and I'm not anti-insurance, okay, so I'm not anti-private insurance, but I'm wondering what the contract that a person who is going to purchase your health care plans signs up for understands when they read that benefit package. So is there any language in that contract that they sign that says that they may not gain access to those visits, or that you may not have consistent visits, or, I mean, explain that.
Yeah, we offer, healthcare benefits for care that's needed to our members. I guess an analogy is we provide a benefit to a cholecystectomy, and maybe Dr. West knows what that means. That's removal of your gallbladder. And so as some of the members of the committee know, or Madam Chairwoman, that's only something that you want to undergo if you need it. So the benefit is one, but it's not like you fulfill it each year. That care offered has to be appropriate. And that's what we're trying to achieve. That's what the Berea Collaborative is trying to achieve, is that the care be appropriate and necessary.
So I actually enjoy the Berea Collaborative. I think they're doing good things, but with all due respect here, how do you know what's best for the patient when you're not the one seeing the patient? Well,
it's a trend throughout the nation that we have these appropriateness criteria, and that it be done for not just the musculoskeletal realm, but also for radiology, for my own profession. It's where you have a third, a second opinion to tell that clinician, or to see if that clinician is aligned with those guidelines and care that are nationally accepted.
Thank you. I appreciate that. Well, no thanks. Since you say that you are ultimately responsible for some practical things, what is your standard turnaround time? We've heard repeatedly from the providers it's a week. Someone in pain, I question that. So by your contract, what is the goal for turnaround time to get back to the provider?
Yeah, truly as short as possible. And these
no, what is it?
These examples are unfortunate where it takes longer, but usually and I think we'll see from the next presentation that usually it's a matter of just hours. For the majority of cases.
I have a whole slew of providers behind you, all shaking their head. I guess, call me from Missouri, I don't believe you. Okay, let me ask you this. Do you ever follow up then with the doctors to see that the outcome was adequate and whether it was taken care of?
Well, we do allow these conversations, peer-to-peer conversations, to see if there's further information they want to provide or information they want to give.
So the answer is no. And honestly, the providers that we had here gave very real situations. And frankly, we had a meeting, Senator Short and myself, with the carriers at the beginning of December. And frankly, we've seen no movement. We've not seen anything better. So let me ask you this. Do you ever follow up with the patient to feel like they were properly cared for when you peter out the visits like this?
Yes, frequently. Just last week, in following up and explaining what we do. In some cases that we do need to reconsider. In some of the unfortunate examples that were presented earlier, we like to follow up with them and to make sure that that case is resolved. We have no interest in there being denied care that's not appropriate or for there to be dissatisfaction.
Representative Harris.
Thank you, Madam Chair. I always marvel, having been vice president of a medium-sized company, when a company decides to farm out its ability to be in touch with its consumer. I find it always odd. So I was wondering, what prompted you to leave yourselves the contact and go to Evicore? What prompted that?
Well, this was a realm of musculoskeletal health, as I said, that we didn't previously manage. There's an objective measure of degrees of healthcare management by Milliman, which shows how loosely things are managed or how tightly. And we really hadn't been offering our members the appropriate medical management. And so we went to the expert, the national expert, that 100 million other Americans are also using.
And then I guess just a simple, to me, you've given some great explanations on difficult things. Just hearing the lack of just computer readiness for in-office, minimal of remembering certain things within the computer program. I appreciate you're having weekly meetings and monthly meetings, but getting down to the actual practice, have you chatted with the practice on the beautiful computer program that they're offering and the ins and outs? And I don't know how long you've been on it, but I would be incensed if I was an office manager and was having to re-enter the same data into the same frickin' system time after time after time. To me, that you sat down and gone over great cases is great, but I'd love to know why we haven't addressed the most minimal, simple system within. Can you tell me why?
Yeah. So I'll just comment, Sean. So it's been very clear that the user experience is in need of significant improvement. We've heard that, and there's been ongoing discussions, and again, we'll allow Evicore to allude to that, but that's clearly on the radar, and it's something that's actively been worked on.
So how long have you been working on that?
They just got into Evicore, right? I mean, Primera, how long have you been with Evicore?
How long has it been?
About 6 months.
Yeah, about 6 months. So, so I can tell you, based on my knowledge, it is being addressed.
I can answer if you'd like me to answer that. I can answer that.
Okay.
David
Well,
Mayer.
maybe later. I'd just like to know why the major players in it haven't. I'm assuming that's a couple strokes of the key for these guys. So I can't be tops on your list. It doesn't sound like, because those are very simple fixes, men. So thank you.
Okay, Representative Caldier.
Thank you, Madam Chair. So you had earlier said that you kind of likened yourselves to kind of a second opinion. So for providers in our state, we have a system where if the provider is overdoing care or not providing adequate care to the patient, people can appeal and they can actually get their license taken away and their job, basically their entire livelihood will be gone. So would you be supportive of having a similar system in place so that in the event that you continually deny benefits for the case of a woman like Stephanie, that then they could have an appeal and have your guys' license or jobs removed? Is that something you'd be supportive of, since you guys are a second opinion?
No. Of course I wouldn't say yes, but I guess our aim is trying to achieve is to make sure that we make the health care that we reimburse, make sure that it's appropriate, that it's helpful to the patient. And listen, I struggle with this. My colleague referred to some numerous ways that have been tried with failure. This really across the nation is the trend, and one of the best ways that we find to really to be able to get a handle on this growing problem of overutilization, inappropriate utilization, unnecessary. I'll admit that it's not without its imperfections. And you cite something very important that I think is intolerable, that it be burdensome to the provider. And we have made efforts in terms of improving that portal, as the OIC has confirmed in the letter that I gave you. But it's currently the best way that we have is to provide that management, that oversight through this expert program.
Okay, you get the last, then we're going to move on. Representative Maycomer.
Thank you, Chair. I have a quick question. It sounds like we have a business aspect, we have a medical aspect. On the medical aspect, my question is, when you're doing musculoskeletal work, so on the managing healthcare, is there a bell curve? And there is actually, but I need to know the ratio. So response to long-term healthcare problems. So the sooner you respond, as you well know as doctors, the quicker the individual can be, back to work or back into a healthy form. And when that occurs, you spend less money as an insurance company over the long-term care, and sometimes results in non-surgical responses. And so when that occurs, there's an economic response. So can you go ahead and email me, or if you don't know it, the bell curve or the ratio of the quick response to a skeletal muscle and long-term care? And I believe that the response is because the muscles will sometimes, as you know, seize or cause problems over long term. Do anybody know the response to that?
If I could ask a clarifying question. You are talking about in terms of the physiologic response or versus the turnaround time in response from Evicore?
The physiological response.
Okay. I personally, I would say, I think it's variable depending on a number of things. I would agree, though, in general, having rapid response and addressing the issue through any number of different ways, it's not something that you want to be prolonged. So, but if maybe we can I can touch base with you and get more further information so that we can respond.
I think the committee would appreciate that. The AMA, I believe, has a response, and I'm sure you guys do, your physicians.
Okay. All right. We got to move ahead here.
Thank you, Madam Chair, committee members. I appreciate the chance to come here and talk to you. We have some slides. We'll run through them. We just want to get everyone on the same baseline. Now, there's some confusion, maybe mystery, who this third party that's very tightly regulated, as Dr. Hyatt said, behind the scenes is Evicore. So we'll give you just a quick overview of who we are. Don't want to dwell on that. And then we're going to go specifically into some of the more Washington State specific statistics of the cases we're seeing here and what we're seeing in terms of the how intrusive we are or not to the process, because that's very important to us. This is my colleague, Dr. Todd Nakasuda. He is a licensed chiropractor and one of our many, as Dr. Hyatt said, 1,000 or more clinical people on our staff at Evicore who make these decisions every day. So our purpose at Evicore is to empower the improvement of healthcare by connecting patients, providers, and payers with intelligence, evidence-based solutions to enable better outcomes. And a lot of that is tough because when we talk about enabling better outcomes, we do talk about measuring outcomes. And I think you saw some of that in the testimony earlier. And we are always in a little bit of a stress here of how do we make sure that the providers are documenting, collecting outcomes to external standards so the patient's getting the best care possible and not being intrusive to the process. And that is something that we are constantly trying to improve. I'm not going to claim we have it perfect. I do think we do it pretty well. But that is our aim at Evicore. We do have 4,000 employees across the country, including 1,000 of which about 1/4 of our employees are licensed certified clinicians, nurses, therapists, doctors, chiropractors. About 520,000 providers are engaged by us. We have small plans, we have large plans, but all in all, we have 100 million members that we manage every day across a variety of products, including all the musculoskeletal solutions that Dr. Hyatt mentioned, as well as radiology solutions, oncology solutions, laboratory management solutions, et cetera. We do manage patients in every state of the country. We are URAC and CQA certified as well as High Trust certified, which is obviously very important when you're talking about IT and healthcare. In terms of our musculoskeletal solution experience, and we talk about musculoskeletal, we're talking about joint surgeries, spine surgeries, all of the conservative cares, and we at Evicore are huge fans of conservative care. We every day direct people or help to direct people away from radiology studies, away from surgeries, and ask those doctors to consider a second opinion or considering physical therapy first, chiropractic care first, other therapies first, before they go to more invasive care. So that we are big fans of these conservative therapies as well. We have 34 million lives that we manage musculoskeletal services for, again, in all 50 states. Those cover commercial lives, Medicare lives, and Medicaid lives. And we do about 4,300 cases every day in those musculoskeletal services. Someone asked earlier, and I apologize, I forget who it was, what the basis of these guidelines are. So the guidelines that we base our decisions on are publicly published guidelines based on external evidence. So every year we are revisiting and improving these guidelines based on what's the latest evidence. When we do that, we're going to go through external national societies, and we're going to present those to them. We're going to get their commentary on them. That includes the American Physical Therapy Association, includes the American Occupational Therapy Association, the American Chiropractic Association. That's probably most relevant to what we're discussing today, but all these others up there as well, anesthesiologists, et cetera, that we deal with every year as we go through these guidelines and make sure that what we're basing our guidelines are and how we're presenting to the public is completely aligned with the best medical evidence possible. In addition, we do have quarterly meetings with Dr. Hyatt. We have our provider associations meet with providers, and we do that with almost all of our plans. And so at Evicore, we're meeting consistently with providers from around the country to get feedback on our programs and to always make them better. We do have 50 therapy, alternative medical specialists. We have acupuncturists on staff. We have massage therapists on staff. We have physical therapists. We have occupational therapists. We have, in all of our therapy skills, we have pediatric specialists. Pediatrics have to be treated very differently. The guidelines are different. The treatment patterns are different, and we recognize that. And we have pediatric specialists that review all those pediatric cases as well. We have 250 medical directors and 700 nurses as well. We do have within our system specialty-based routing, so we make sure that the cases, and you'll see a little later on, but I want to clarify, we do approve cases very quickly without a clinical person reviewing that. But any care that is requested by a provider that is denied or altered in any way, by altered I mean perhaps reduce the number of visits from what they've asked for. If they ask for 20 and we approve 10, ask for 5 and we approve 3, anything that is at all altered, reduced, or denied has to go to a licensed therapist, licensed chiropractor, a licensed physician in that specialty to be reviewed, to be denied. It never happens any other place, and we are audited constantly, and there's no question that's exactly what's occurring. We do provider engagement when we roll out new programs, and I think, as Dr. West said, there is opportunity for improvement here. I think we learned that from our experience with Primera. And we do fax blasts because we know that doctors often still use fax. We do put things out there in the mail. We do notification letters to every provider in the area, every provider in the network. We do webinars multiple times before it comes up to say, here's how you submit a request. Here's how you get in touch with us. Here's what the terminology means on our sheets. Here's what to look at. We even do outreach, in person to large provider groups in the area. We will fly out in person and meet with them and train them. All that said, these guys are caring for patients. We understand that. There's something they may not have time for a webinar, make time for a webinar until the day after the pre-authorization process starts, and suddenly they're like, what do I need to do here? How do I get involved with this? So we'll have follow-on training as well. But that is something that we are always focusing on. We have an entire provider engagement team that focuses on that, but we do acknowledge that we need to continually get better in that process. The therapy review process, chiropractic review process, very similar to all of our processes. So most of these cases come in on the web. We still have some coming on fax and some coming on the phone. I'll show you a little later on specifically for the therapies in Washington and what we're seeing in terms of that. Most of those do come on the web. The web is nice because you can get that immediate approval, and a high percentage of our cases do get immediate approval. Again, if it's not immediately approved based on the minimal clinical information that's being put in on the website or given over the phone or on the fact sheet, then that always 100% of the time is going to be routed to a licensed clinician to review that case. They may ask for additional documentation. When they do that, we're really just asking the provider to upload the documentation they already have on that patient so our reviewers can review it. Someone asked earlier, how long does this take? It may take as little as 5 to 10 minutes for a therapist or chiropractor to go through these. It is very frequent to take 15 to 30 minutes or longer. For pediatric cases, often takes longer because there's a lot of documentation to pour through. We're not asking the providers to fill out sheets and sheets and sheets in our format. We are trying to go through in their format and understand what they're doing, why they're providing the care they're providing, why they're requesting the visit they're requesting, and what that patient's progress has been to date. If there is a decision that the provider disagrees with, there is always the opportunity for a peer-to-peer conversation. And again, we will schedule that with the office to make sure that it's minimally invasive to the clinician that's treating the patient and get on board, get on the phone with one of our clinicians and talk about the case. Always our physicians have the complete authority at that time to immediately approve whatever they want to approve with that conversation. That's usually how those resolved. They come to a conclusion to approve or deny or give a certain number of visits in this case, and that is immediately processed on that conversation and out the door. We do view ourselves as partners in healthcare, and I understand that with partnerships, there are different players, and we are not the people seeing the patients. We don't try to be the people seeing the patients. How do our clinicians make their decisions? They're looking at the physician's notes, physician's treatment plan, and the progress that physician is reporting, and making that decision. If necessary, they're talking to the physician to find out about that. And Dr. Todd, do you want to say anything else about that, about how you process the reviews and make your decisions?
Sure. Thank you. So it certainly is an involved process. There's an imbalance between collecting information and is that information collection process too intrusive, that we're collecting too much information, or it's not enough information in order to render a real sound clinical decision. So over time we have refined this process, and certainly we are trying to incorporate outcomes assessments, which really are the gold standard that really we want to move towards. And we do prompt providers for this outcome assessment information when they do enter our portal and give us information. Now, it is an optional field, and we don't always, that information isn't always made available to us, but certainly we're aware of that, and we're making that, we're trying to collect the best information available to make that decision possible. Sometimes that information is 100 pages of progress notes on a case that could take us a long time to wade through and make a clinical decision. Sometimes we can make that decision based on the 2 or 3 page worksheet that we collect from that. So there is a wide variety of cases that and complexity that we look at, and the time that it takes to compile and complete that decision can definitely vary from just a few minutes to much longer than that.
So I want to talk to you a little bit about the wonderful state here and what the experience is here. So in the last, this is actually I think 2016 and 2017, that first number, so about 245,000 cases in the last 15 months. What we've seen is that about 2/3 of those cases in PT and OT get resolved. The episode of that patient gets resolved in 6 visits or fewer. And for chiropractic, about 81.7% of those episodes are resolved in 6 visits or fewer. You'll see why that's important in the future. I do want to make a note here that, one of the things that's important to understand is a benefit may give you 24 visits in a calendar year or in a benefit year. Part of what we're doing is trying to make sure that the therapist who's seeing you right now, and that may be a shared benefit across physical therapy and occupational therapy or across other fields, is using what they need for this condition. Because you don't want to get injured in January and have that therapist use up 24 visits by midway through March, because they had 24 visits to you, so they saw you 3 times a week for a few months. You want someone else saying, hey, here's an appropriate progress of care, because you still have the rest of the year left. And so we're not trying to meter out those visits. What we are trying to do is constantly say, what is the appropriate progress this patient needs to be making through this therapeutic process, and based on the evidence-based care and the guidelines. And so there is a reason why we do see most of these episodes resolve in a relatively few number of visits, and there are outliers. We acknowledge that, and those outliers have to be dealt with. And those outliers, even if just one outlier, is a real patient with a real condition and a real job and a real family, and we understand that and take that very seriously. Again, trying to stay have as little burden as possible in the process. This is an important number for us to look at, which is how often does someone have to come into us more than twice? So through the entire episode of care for that patient, from when they first see the patient and the initial assessment until the end. I mean, you heard horror stories today, and I agree they're horror stories of someone coming in again and again and again, getting 2 visits, getting 1 visit, and coming back to us 5 or 6 or 7 times an episode. That's not acceptable to providers. It's not really acceptable to us either. 92% of the time, we do see patients come to us, providers come to us for a patient episode 2 or fewer times. So just 1 or 2 times is the entire request they make. They make 1 request, they get that initial set of visits with no clinical notes needed, and then they come back a second time and may have to provide some clinical progress, and we'll approve additional visits. And 92% of the time, that's the last time we interact with the provider on that episode. And that means, there's only 1 clinical review or fewer of actually asking for detailed clinical information and outcomes on that patient per episode of care before the provider stops asking us for more care for that patient, because they've gone through the entire treatment plan for that patient for that episode. Again, a patient may have multiple episodes during the year. We do think that's important because we do try to keep our eye on having as little burden as possible in the process. And this is my last slide. Again, I promised you would see. So for the state of Washington, a little over 80% of our cases do come in on the web. About 95% are fully approved every time they come in. So we're really talking about that 5% or less than 5% where we're really having this clinical review process and adjusting the number of visits or saying the care is not appropriate.
Senator Short.
Thank you, Madam Chair. I'll be brief.
Yeah.
First of all, we can follow up, because I think I would really like to see your records if you could look at Washington State, but specifically Eastern Washington maybe,
okay,
and just give us a look at those visits to see how many visits you have, over a certain period of time. Like,
okay,
what does that look like, or do they just dribble in? And then my last question is, who are you? You say you're highly regulated by whom?
So URAC and NCQA are 2 external associations that come in and audit us and approve us every year. We also, anytime our health plan partners are undergoing audits, undergoing regulation, as a third-party provider, we're often going to be involved in those as well.
But they're not. Representative Schmidt.
Thank you, Madam Chair. I just have one comment. And I hear from the consumer on the other side, and that's where this comes from. How come whenever I hear about problems with program benefit managers, it's always Evicore? And that's my comment and my question. I don't hear about any others. That's the one. So I would think that there's some problems that need to be addressed, and either by the carriers or by yourselves. But that's the one I hear about.
Representative Collier.
Thank you, Madam Chair. So earlier you had said that one of your concerns as an insurance company is the overutilization and the fact that a patient may go in and the physical therapist might use up all of their visits, and then they won't have any more benefit if something else happens. But wouldn't the patient say, hey, this isn't working, and maybe stop going to see the physical therapist at some point? I mean, I think it's very kind as an insurance company that you're so compassionate about that, but has that ever happened?
It actually does happen. And I can't tell you how often that happens, but I will say that, the number of visits we authorize is not always fully utilized. And I don't have the numbers here in front of me, but I could get back there and tell you, for when we authorize 6 or 8 visits, may only use 4, may only use 5, and it's done. Some percentage of that is a therapist finishing their work and saying, you're now independent. You're doing your homework, you're doing your exercises, you're good, you don't need to come back and see me again. Some of that may be the patient saying, this isn't helping me, I'm going to try a different route. I don't know what the breakdown between that is, but I agree there probably is some of that, of the patient saying this isn't helping me. Dr. Hyatt, do you have any experience with that or any knowledge about that? Dr. West?
About patients not
feeling the benefits from therapy services? Or
Yeah, a lot of times there's that tendency to as suggested, they just pursue, they just keep getting the treatment.
Do what the doctor told them to do, yeah.
And sometimes it's nice to have that that expert additional opinion, maybe saying that there's a different way, there's something else that you can provide. One thing that's been, I think, very good for our members is that weekly case conference where we do actually consider those members who chronically have been treated one way, and it's like you just keep doing one thing where maybe you should try something different. And so we discussed that, and it could be that they've been trying some conventional technique when really maybe they should try acupuncture or chiropractic.
In those weekly conferences, are you discussing including the primary care provider or the provider that's dealing with the patient, or is it just you guys?
Well, it's an internal discussion with Evicore's experts, with our own people. We'll have a pediatrician, we'll have nurses, and then we share that with the provider.
So how does the interaction then go with the provider? Does the provider get to say, well, actually, we tried that and it didn't work, or the patients had a reaction in the past to the drugs, or,
There is some back and forth.
And just to add to that question, typically we have access to records, so we have that information beforehand as we discuss the case as a group.
So I have a few questions. I've waited till the end here. So by law, I know you have 14 days to respond to the prior authorization request, because I get told that regularly, that you have 14 days, or, that when people, and you don't have to respond. So for Regents and Primera, do you track what the average response time is, so you know what percentage is responded in at how many days? Sorry. Do you, or I guess it's through.
So we do, so yes, Primera and Regents stay on us for that constantly, and because they are very concerned with that response time and the impact to their patients' providers, and we provide that every month. We're providing reports. We provide that more frequently. When we had the rollout problems with Primera, we were actually reviewing that daily at I don't know what time it was here out here on the West Coast, maybe at 6 a.m. every morning. We're going over the previous day, everything, and what was in the system.
Then I would ask maybe if you could share some of those numbers with the committee, since that's where there's a lot of skepticism.
Yeah.
And the other question, just that you brought up the BRIE Collaborative, and which, of course, I feel like I'm the mother of BRIE. So the question I have on that is, in the BRIE, we were discussing bundled contracts, bundled payments, and contracts for outcomes. Are you thinking about that for the physical therapy chiropractic going into that direction? Because it seems to me that's some of the problem, that if you're going to pay for outcomes, which I totally agree with, that we need to be looking at, okay, you're going to get this much, make them better, and we don't care how many times you see them. So are you guys looking at that?
I would say that that's something we discuss in multiple areas and multiple arenas for multiple types of care. And again, to the extent that the provider is, sort of has an episode of care to achieve an outcome, I think there's value in looking at that. So the answer is we're evaluating those, and how to implement those is very challenging.
I can say we are actively in discussions with other Blues plans, not actually with these two, with some therapy groups elsewhere in the country to do exactly that.
And do you use gold cards anywhere? Because I know radiology, that's where I think the terminology came up from. And so you're absolutely right. There's a difference between therapists, and some can get things done in 6 visits and some will take 12. But the question is then, do you give any recognition to the people that are actually the best performers and have the best outcomes, and give them less hassle? That's, I think, one of the questions that we continually have.
I would like to get there again. When we rolled out the program with Regents and with Cambia, we actually had a tiering process, which I don't know if you're familiar with.
Oh, I remember. That's the last time you were here.
So that was the attempt to do that, to give recognition to top performing providers. Without the outcomes data, it was decided by everyone involved that we probably, just by looking at the number of visits per episode, was not an acceptable way to do that.
Right.
We at Evicore are actually actively going after the ability to reach out directly to the patients during care in all of our therapies and surgeries, prior to care, during care, and then at appropriate follow-up periods afterwards, to get the same outcome measures for the same patient conditions, regardless of what track they go down. If they go on a track of pain management through injections, through therapy, through surgery, to get externally recognized outcome measures collected on those patients, so we can begin to, again, even improve our evidence and outcomes based on that. that will be a little while to build up the data. But we
Well,
are
and I
doing
guess
that.
to get back to my questions, that I still firmly believe that we have more opioid use because of the therapies not getting utilized as quickly as they need to be. Has either Regents or Premera ever looked at the high opioid utilizers and then to see what their access to therapies was and do any comparisons on that?
I don't think that we've looked specifically at that. However, we have an opioid diversion and other opioid use programs, and I think I can bring that back to look and see if that's specifically been addressed.
And I guess maybe that's going to be my study when I retire. Okay, thank you. We need to move on.
Okay.
So we're going to move into the cardiac and stroke system of care, and we have Lindsay Hoven from American Heart Association, Myra Wilson, and Dr. David Tershwell.
Good afternoon, Madam Chair, members of the committee. Thank you so much for the opportunity to be in front of you this afternoon. My name is Lindsay Hovind. I'm with the American Heart Association and American Stroke Association. We would just really appreciate the chance this afternoon to share with you a primer, if you will, on our statewide emergency cardiac and stroke system of care. We'll share a little bit about the impact of cardiovascular disease here in Washington, how our system came into being, how it's structured, and then also perhaps some opportunities that we feel we have in front of us to further strengthen it. You'll hear from my friend Myra Wilson about her personal experience with the system, and you'll also hear from my colleague Dr. David Tershwell of Harborview and the chair of the Technical Advisory Committee that oversees the system. You are receiving two handouts, one of which, the one that folds open, the two-page handout, was created when the system was first established in 2010. And put into motion in 2011. And I just think there's a helpful graphic on the front there that shows the continuum of care that really illustrates the system. And then a second handout, some facts and figures provided by the Department of Health. So I want to just ground us all first in a very important piece here, that sudden cardiac arrest, heart attack, and stroke are all time-critical emergencies. So we spent the last hour and a half hearing about things that can be resolved perhaps over 3, 4, 5, 8, 10 visits, but we're talking about things where perhaps 90 minutes is the window that we have to get appropriate treatment. It may be 3 or 4 hours. So we just want to remember that time lost, a delay in treatment, means brain tissue lost. It means heart tissue lost. So it's absolutely critical that we minimize the time from symptom onset to treatment. Heart disease is the second leading killer here in Washington state. Stroke is the sixth leading killer. And also it's important to note the number one cause of disability in the state. Taken together, these two conditions are the leading cause of death in Washington, accounting for a quarter of all deaths in 2015. Stroke and heart disease together accounted for more than 3 times as many deaths as trauma and more than 7 times as many deaths as diabetes. According to a study that the Heart Association recently published, over the next 2 decades, it's expected 45% of the U.S. population will have cardiovascular disease, and that statistic encapsulates congestive heart failure, hypertension, stroke, a number of things. But I think it's important to note that this is going to continue to grow, and we want to make sure that we're addressing it appropriately in our state. More than a quarter of Washingtonians are living with diabetes, hypertension, or high cholesterol, all major risk factors for stroke and heart attack, as well as smoking, unhealthy diet, and physical inactivity. So again, as we perhaps see the growth in these risk factors, we can expect a growth in the incidence of heart attack and stroke. Cardiovascular disease is incredibly costly. Here in Washington in 2014, 26,000 hospitalizations due to stroke and heart attack led to more than $1.66 billion in hospital charges. So all of this to say the impact of these disease states are significant, both in terms of lives lost and financial costs. So our statewide emergency cardiac and stroke system of care, it's intended to ensure that care for these heart attack and stroke patients is coordinated and all patients receive the right treatment at the right place in the right time, no matter where they are in the state, thus increasing their odds of survival and minimizing disability and costs. So with that, I'd like to invite Myra to share her story with you.
Hi, thank you for having me. I'm Myra, and I'm 43 years old currently, but 2 years ago I was 41 years old, and I was working at a hospital in the south end of Seattle, as a student nurse, and I was giving a report to one of the nurses, and he recognized that I was showing signs of stroke. I had slurred speech, blurred vision, had headache, and facial droop on the left side, and I experienced weakness on the left side as well. It happens to be my dominant side. And they called the code immediately there in the hospital and evaluated me, and they determined I was likely having a stroke. So they took me to the ER there, and I underwent a CT scan to determine whether or not it was hemorrhagic, and it wasn't. So I qualified for the clot-busting medication called TPA, which was administered at that particular hospital. However, the clot was too large and didn't really respond to the TPA, so I was transferred to Harborview Medical Center, where I underwent what's called a thrombectomy, where the physician was able to go into the femoral artery and the groin, thread it through the body into the brain, and then remove the clot. So I spent, after that, a week in ICU and then 2 more weeks in stroke rehab.
So I really appreciated Myra being with us today because I think it's an illustration of this continuum of care and the importance of this system. So while not everyone is fortunate enough to have their stroke symptoms identified already in a hospital, I think that recognition of signs and symptoms, that quick administration of TPA, and then coordination with the other facility does demonstrate our system here at work. So I turn to Dr. Tershwell at this point to give a little more background on the system.
Thank you. And good afternoon. My name is David Tershwell. I'm a stroke neurologist. I work at Harborview Medical Center, been working there on the staff for over 20 years, and I've been working with various committees that had various names at the Department of Health for 15 or plus years on stroke and cardiac issues as well. So I was around when most of these things happened. So Washington.
So was I.
I'm glad neither of us maybe has had to use them just yet. So the statewide emergency cardiac and stroke, that's what ECS stands for, system, how it works. The design in 2008, the Department of Health convened a work group that looked at the state of affairs for cardiac and stroke in Washington State and came back with a pretty thick report that had a bunch of recommendations. These recommendations led to enabling legislation. You can see the RCW number there. You're probably more familiar with some of that than I am. That was eventually passed in 2010. But in many ways, and I think we'll come back to this at the end, it was an unfunded mandate. There were lots of great things that were suggested to be done, but there was not then, and there has not been since, any money appropriated to really enable many of the recommendations to come to fruition. The structure of the system, at least at the hospital level, was that different levels of hospitals with various criteria based on national standards, different levels of hospitals were created. So for cardiac hospitals, the level 1 was the higher level hospital that had more resources, and then most smaller hospitals could be cardiac level 2 centers. And for stroke, there were actually 3 levels. Level 1, again, being the most comprehensive stroke centers. Level 2, a more intermediate level of resources for stroke care. And then level 3 being a lot of the smaller hospitals. And the idea was that all of these systems should allow almost all of the hospitals in the state to come in and participate in the system. And participation has a lot of different bits and pieces. And so here we just have participation as far as the Technical Advisory Committee, the TAC goes. What the TAC's job was to define what resources a hospital had to have to be level 1 or level 2. They created, along with a sort of a multidisciplinary group of individuals, content experts, hospital people, nurses, doctors, EMS folks, put into place recommendations for emergency care and emergency triage of both cardiac and stroke patients that have been implemented statewide. But again, there's no way to really check on the implementation because there's no funding to allow for, comprehensive data collection and review. The hospitals, on their end, to participate in our system, and again, mostly based on the lack of funding, the hospitals fill out some forms. They testify to the fact that they have certain things in place. They send their application into the state, and it gets approved. There's no verification of the resources at the hospital level. And then emergency medical services around the state. Leaders in EMS have participated by helping us create the triage algorithms that they use for identifying and caring for stroke and cardiac patients, and then also help determine the destinations based on the state-based levels. The final bullet point here, why is a coordinated system critical for patients? Well, as Lindsay was saying, when you're having a heart attack or when you're having a stroke, literally every minute counts, and depending on which type of heart attack you're having and which type of stroke you're having, you may have a 3-hour time window for therapy, you may have a 90-minute time window, you may have a 6-hour time window. Can't tell all of that, obviously, in the pre-hospital setting, so knowing how to diagnose these patients, having a rock-solid plan for where to take them as quickly as possible, and then having a rock-solid plan where you take them as to how to diagnose and treat them, and then a rock-solid plan as to what's next. Do they stay there? Do they need to be transferred to a higher level of care? Our state has a lot of rural areas, and so a lot of these smaller outlying places obviously don't have the resources that some of the more comprehensive centers have. Go to the next slide. So what are some of the limitations that have become apparent, I think, to providers over the years that this system has been out there but hard to cement into place? Well, self-identification of facilities may not always be reliable, and it's a little bit cynical, I have to say, but I think that with the self-identification system in place, there's a little bit of grade inflation. So how did I do on that test? I think I got an A. And so, for example, there's a mismatch. There are actually national accreditation agencies that can certify hospitals, and I'm a stroke guy, so I know a little bit more about the stroke than the cardiac stuff. So there are national bodies that certify primary stroke centers, which is kind of like a Washington State Level 2 stroke center. I think there are 33 Level 2 stroke centers in the Washington State system, but I think there's only maybe a dozen or so that are certified by a national body. And really those resources are supposed to line up almost exactly. In fact, we designed it so they would line up pretty much precisely. So the whole self-identification without verification is an important issue, and of course verification largely will lead to the need for some funding. There's also limited data that are available to the Department of Health to allow them to engage in continuous quality improvement. New treatments continue to emerge and hopefully will continue to emerge for cardiac and stroke, demanding sort of continuous evolvement of our systems of care to optimize treatment for patients. Even if we fix it today, we're going to need to redesign it a little bit tomorrow, and really this system of always looking at it, gathering data, figuring out where our opportunities for improvement are, it is a continuous process. There will always be a need. We will never be done improving the system. And those sorts of activities also take support. So the lack of funding at the end there precludes the Department of Health from offering technical assistance and system support to help these things get done around the state. There's also a lack of public education for heart attack and stroke signs and symptoms and the importance of calling 911. And then the rural issue is really unto itself another difficult thing to tackle. Obviously, small hospitals need to have in place clear systems of communication, and the ability to rapidly transport patients, if they need it, to more comprehensive centers. Our EMS and cardiology colleagues remind us that specifically there's a lack of getting to do an EKG in some of the EMS vehicles in the rural parts of our state, which also could be fixed potentially with some more funding. And there's difficulty not just in training, but in recruiting, retaining, and training EMS folks in the rural setting who are largely on a volunteer basis. Thanks.
Thanks. So I think Dr. Tershwell outlined really nicely for us over the last 6, nearly 7 years that the system has been in place, some of the areas where we just know that we can do a little bit better. So there are a number of stakeholders who have an interest in working with the Technical Advisory Committee, working with partners like the Heart Association and Stroke Association, and we're hoping to be able to look to this body as well for some guidance and support as we really suss out where we want to go next with the system. So just to kind of recap, and Dr. Tershwell hit so nicely on a lot of this, we do think that perhaps there is something that we can do around this question of self-identification. Could there, that phrase, trust but verify, right? Could there be some verification? Does that look like looking to national certifying bodies, as was mentioned? Does it look like perhaps looking to national certifying bodies for those higher level hospitals treating the most complex cases, and perhaps looking to our own Department of Health to do something for those lower level hospitals, those critical access hospitals? So we don't know. We're open to exploring what those answers might be for our state. So an open question there. The limited data, I think a statewide data system is really the way we're going to be able to always pinpoint where we need to be doing better. A lot of these data pieces may exist. Some hospitals have some data in some regions, but right now it's disparate. There's no one that can really pull this together and allow us to look at a system level, look at it from the system level, looking at both pre-hospital and hospital data. And then lastly, it's challenging to support a state system without state funding. And I know that that's always a challenge down here. And this year, I know you're just getting into that part of session, so I'm going to cover that part real briefly. But, you know, we do have some real limitations, and especially some of those rural limitations. We can't quite take care of that because we don't have the money to do that. So I think all of these things are areas where there's stakeholder interest and support, and we appreciate the opportunity just to hopefully start this conversation today, and we'll continue to try to convene stakeholders and, again, hopefully look to this body for some guidance and support as we do this. So thank you, and I think we'd all welcome your questions.
Representative Schmick's got one for you.
Thank you. More of a comment. I have 6 critical access hospitals, and the one thing that I see across all 6 is the telestroke protocols, meaning that when the ambulance is coming in, you know, from wherever, they are all set up, they're ready to go, and the amount of transports then have been cut down dramatically. But they also know, because they have that ability to have the doctor there, you know, but even though it's by video screen, but he's directing the care that needs to be, that has saved lives, frankly, in our critical access hospitals.
And you notice that it's very white in his
Yeah, I'm down there where we just got to be a little tougher, I guess. Yeah. But I'm very thankful, though, for that type of technology, because sometimes your resources are limited, and so by the use of that, I know that that's helped a lot of folks in our communities, and so I'm very appreciative for that, because that's where I live, and those are the people who I serve. So thank you.
If I may, I think that's a wonderful comment, and I think telestroke is certainly an integral part to this system. So I think your point's very well taken.
Representative Slatter.
Hi, thank you very much for your presentation. And I'm interested in Alaska. I know they have an Alaska Native population as well, and they certainly see their share of, you know, a disproportionate number of cardiac issues, certainly familial and others. And I'm just wondering, there's a lot of rural populations there, and is there a model in that state for funding and support of those populations? Do you know?
I don't happen to know the answer right now, but I'm happy to work with my Heart Association, Stroke Association colleagues to circle back with an answer for you.
One follow-up. Madam Chair? And I am interested, the ACA, now that it's continuing, I know, this is the second leading cause of death here. It certainly can be one or two in the country. I know that that's going to be a consideration as they look at preventative measures and are looking at outcomes data. Would you be co-locating with them in that conversation? Because there's a lot of communication happening on that front.
I can speak for the Heart Association and Stroke Association to say that we've very much been a part of that. We were advocating for the essential health benefit to include all of those USPS TF recommendations from the very beginning. And I know the bill that's been moving this session, we've been supportive of that as well. I don't know that the Technical Advisory Committee for our state system has necessarily had a role with that, but Dr. Tershwell, would you have a comment?
Well, certainly we're all interested in, the best outcome from a stroke is the one that never happened, for sure. We are called the Emergency Cardiac and Stroke Technical Advisory Committee, so our charge is largely after the bad thing has happened and coordinating the care. And despite the absolutely tremendous importance of primary prevention, we will never be able to prevent all of these events. And so at least this technical advisory committee is focused on improving the care of patients after the event has occurred. After the event has occurred, of course, there's a lot of things that happen. They're acute care, but also secondary prevention. I mean, nobody's at higher risk for heart attack and stroke than those that have already had a heart attack and stroke, and that is absolutely a big part of the focus of a lot of these data collection instruments, a lot of the QI initiatives as well.
Rodney.
Thank you, Madam Chair. Just had a question about how important are these protocols, obviously, for ER trauma designation? Because I know in King County where I live, ER trauma designations can be pretty political after you get below level 1, level 2, and a lot of hospitals would like to have a higher trauma level, and they can demonstrate they can handle, cardiac stroke incidents. But do you work with the Trauma Council in evaluating applications for heightened trauma readiness status?
So the emergency cardiac and stroke levels are separate from trauma. So I get, and yes, there's politics. I'm not sure what else, I don't know if you want to rephrase the question. I'm not sure what else to say.
There's politics everywhere.
Yeah.
Yes. And that's what keeps us employed. All right. Thank you very much.
Thank you all
for your presentation. And now the last thing we have to do for this session, hopefully, is interim planning. And so I will take ideas from people that they would like to see on the interim plan. I can tell you, I'll just run through. I know, as Representative Slatter, you have talked to me about drug transparency and wanting to work on trying to get the line behind the curtain. That's it, behind the curtain, and some cost benefit analysis. So that's one thing. Of course, we will have a rural healthcare tour this year, because this is the year we get to do one. I don't know whether I call Spokane rural, but well, so anyhow, we will be open to everybody can lobby about where they. And the Squish Committee will continue through the year. The Joint Legislative Oversight on Healthcare Reform, and we will have an aging committee. I don't know how that's going to happen, but I know we will have one. So those will be part of the work plan. So any other, Burton, do you have any dental issues you want to get on here?
No, Madam Chair. However, I wouldn't. One of the things I want to start exploring is the provider network adequacies for various types of healthcare, whether it's dental or ophthalmology. I'm finding.
You're finding that one.
Yeah, finding out with my own. I've got to go out of state, and because of network adequacy for our states.
Thank you, Madam Chair, and perhaps continuing looking at telemedicine and the progress that's been made, and because the technology is moving so quickly and changing so quick, I think that might be something that if we could include that and how that would help our constituents as part of it.
Thank you, Madam Chair. I was hoping we might take a look at obesity, since it has such a strong link to so many other chronic illnesses, and what kind of proven interventions there are out there at this time to really address obesity.
I won't tell you what this one came up with.
It wasn't helpful.
Yeah. I thought you were. We resemble that remark.
We could do a walking. It could be a walking.
Walking to.
Yeah.
There we go. Mm-hmm.
That steals your cheek.
The spinal cord clinic in Seattle. I think that'd be a fantastic. I forget the doctor's name, but.
That's fine. What do you want to go do a tour there too? We could do a meeting there. Yeah. Fix J.
We'll offer him up as a case study.
Oh, well, contagious disease. Probably we'll think about how Department of Health, because depending on what happens with the foundational public health stuff, maybe we'll have to do some review.
What about something to do? I'm sorry.
Yeah, go ahead.
What about something to do with the heroin epidemics?
Oh, opioids.
You know, it's something that we need to keep watching.
Yeah. Yep.
Madam Chair, so I had a conversation with a ED doc who lives in my district, and he was questioning why we even have opioids on the Medicaid drug formulary. He said there are non-addictive alternatives. I mean, we are creating addicts through the Medicaid program.
Well, not just the Medicaid program, but yeah,
right.
all of it. I'd entertain that bill if you want to introduce it next year. And Purdue Pharma will be here to visit you. Go ahead, Representative.
Thank you, Madam Chair. Just maybe looking at the biomedical industry and the innovations that are occurring in Washington State, because the bioscience, we are so far from the rest of the country. It'd be really great to even look at some of those innovations that are occurring.
Oh, maybe we could do a joint thing with them.
Well, we have so many biologicals doing work here. The Norvo disc and the research that they're doing in downtown Seattle, I mean, is pretty amazing. There's a lot of different things happening in the medical fields, and I think that we probably have a lot more than we could ever do on a tour. But this gives you some ideas of what people are thinking.
What things are people interested in? Yeah. Right. You have something?
Well, I think some of the stuff we heard about the behavioral health integration and just tracking that as it goes along, some of that might already be covered, but some issues came up, I think, recently that we maybe want to look more closely at in terms of just pushing innovation on that kind of integration.
All right, well, we don't have to turn this in for a while. So any ideas that you come up with this summer? Well, we'll probably do the tour and maybe another meeting, which maybe we'll do a Seattle meeting to do one of the list, yeah. And then just the meetings that we have because I expect we might be here a while. So maybe, we'll see how that goes. But that would be my expectation at this point. But if you, and as I said, any other ideas you come up with, just pop them by email. And since we won't, no other further meetings of this group are planned for the year, so I want to take the opportunity to thank the staff for all their work. And everyone knows that Alexa's breeding again, right? So that she's pregnant, and so when August, right? So she probably won't be going on the rural healthcare tour. Look at that. But maybe we'll make her plan it. What do you?
That would be perfect payback, though, on her part to plan it for.
Oh no, the planning's the hard part. Yeah. Well, that's true. So, yeah, right. Actually, you know, depending, you may want to go on the rural healthcare tour, but so there's no other announcements from the crew, was there? Yeah, we're not expecting anything at the Blake household, right? Or Jim's ignoring me completely. All right, with that, meeting adjourned.